these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office. Experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all. In-depth discussions.
Breaking it down into simple terms. We hold
these truths.
We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
Welcome back, everyone. With me today is Dr. Marty Makary. He's a faculty member at Johns Hopkins, and he's an expert on healthcare pricing and public health. He's the author of The Price We Pay, What Broke American Healthcare and How to Fix It. It was published in 2019. So, I hear about this from a lot of constituents and a lot of Americans, and I like to use the following analogy. Imagine if we bought food. Another thing we need, if we describe healthcare as something we need, imagine if we bought food the same way we bought healthcare. So you'd go into a supermarket and nothing would have any prices. You'd pick out sort of what you wanted based on whatever limited knowledge you have of what you need. You take it to the cashier. They bill some third party. Maybe you pay a copay or a deductible or something that maybe you knew ahead of time.
But who's your employer?
Well, it gets pretty complicated pretty fast. And on top of that, maybe you wanted to buy tomatoes and then onions, but they're like, well, you have to buy the onions before the tomatoes. And actually you can't even buy that, this before that. That would be kind of similar to how our healthcare system is priced. So you wrote a whole book about this. This is something you focus on a lot. At the heart of everybody's, I think, frustration with the healthcare system is the pricing mechanisms we use. There's plenty of good doctors in the United States. There's plenty of good researchers, plenty of good, interesting, cutting-edge technologies. In fact, you might argue we're still the best at everything across the board, holistically, especially with the really tough stuff. But it's the pricing, right? It's the financing of it. So, where do we even begin? What were you seeing in your practice? You practice as well, right?
That's right.
You do the policy side. You practice. What kind of doctor are you?
I do pancreatic surgery.
Okay. And what caused you to write this book? Just sick of it all? And how did it start?
Yeah, look, there's too many people in healthcare just picking up their paycheck every 2 weeks, frustrated, but they don't do anything. Mm-hmm. And I have been at the bedside with people dying over 1,000 times, and it reminds you how short life is. You got to speak up. You got to do something. So one of the great injustices out of all the injustices that make headlines is the fact that the prices are too high for healthcare, and you can't get the price when you go in for the care. Just like you said, the grocery store.
You can't know what it is.
It's insane. Would you go to a burger shop and ask to see the menu, and they would say, "Who's your employer?" Well, we'll work it out. We can't give you the price. After you eat the burger, then we'll send you a bill.
Make sure you get your burger first. That's what's important. Well, I know, but I'm not sure I want the burger.
Right.
This is especially true for there's some things that you need or you'll die, right? But there's a lot of healthcare in between, your kind of maintenance healthcare and you need this or you die healthcare.
Yeah, 60% of healthcare is shoppable. These are non-emergent, non-urgent services where you can shop, but you really can't because the system
doesn't let you.
The fundamental problem in healthcare is we have non-competitive markets. And when you see that as a policymaker or a consumer, you want to create rules around the bad behavior. But the real solution is let them be competitive, let them be efficient. Just like when you buy a airline ticket on a travel site. The airlines don't say, we can't give you a price.
Nope.
We don't know the price of fuel and,
They have incredibly complicated algorithms that give them a price, and that price changes on a minute-by-minute basis.
That's right.
Somebody can obviously figure this out.
That's right. That's right. They incorporate the variability in their cost into a fixed pricing model, and they give you one price, and that's how you shop. And that's why airline tickets have basically been stable for 35 years.
Yeah, they actually have. Yeah. That is. I've never even thought about that analogy, but if I think about travel over the last 20 years, it doesn't appear to me to have gotten really more expensive. There's still very affordable ways to travel.
Yeah. It was about $200-300 to fly from here to Texas in the 70s.
Yeah, exactly. There's no perfect analogies with healthcare. I try to use food because I want to focus on something we need. Mm-hmm. I was stumped once when I'll never forget it. I was so annoyed with myself. Joe Rogan's like, well, firefighters are like a public service. Like, why can't it just be like that? And I was like, and I started thinking about like economic terms, like, I don't know, like common goods or whatever. But the real answer in hindsight, I didn't come up with it in the moment, but the real answer was, well, I mean, you're comparing apples and oranges right away, right? Mm-hmm. A firefighter has one job to do, put out a fire. A doctor could potentially have millions of jobs to do that last over different varying periods of time. So you're comparing an incredibly simple public service to an incredibly complex one, right? That's number one. Also, number two is you don't need to innovate in the firefighter world, right? Putting out a fire is putting out a fire. There's some little innovations here and there. I don't want to like disparage the firefighting innovation sector, but it's pretty cut and dry, no pun intended. The healthcare is not, right? You're constantly trying to, you need a profit incentive to invest in research and development. And so it's complete apples and oranges. But like, is there a better analogy? I don't know. I look at things we need. We need shelter, food, and healthcare. And in shelter and food, we use a voucher system to give it to people who can't afford it. Am I lacking in my analogies there?
Well, first of all, you got a cool life. You went on the Joe Rogan show, and you're next door here to AOC's office.
Yeah, we are. Yeah, we're new neighbors.
That's good. Cool.
And we're working on some healthcare stuff together.
Oh, good.
Psychedelics therapy. What do you think about that?
Yeah, there's some interesting data there.
Yeah.
Interesting data. Yeah, there's too many labels with medications that are non-productive. Like this is a drug. What's the difference between a drug and a medication? I mean, so we should rely on the data to tell us. And same with public policy. There's too many labels and all that. But in healthcare, the system was working pretty good until we had generated a giant middleman industry that is sieving money out of the system left and right. And that industry is fed off of one principle, and that is you can't get the price. You can't see the price. So a giant repricing industry moves in.
When did this happen? Like, if you're looking at the history of healthcare pricing, because that is true. I mean, and my parents don't recall a time when healthcare was so unaffordable. It wasn't a thing. We were probably lower middle class. My mom had cancer. Like, this was a big deal. I mean, I don't recall it being a devastating issue financially.
Well, the first insurance company really came out of Texas. It was a group of doctors in a hospital that said, hey, we can just offer a sort of plan so that you can make sure you get cared for here by contributing on a regular basis. And the system worked fine, but then what happened was in the 1980s, a bunch of consultants out there went shopping, they went bouncing around to the different hospitals and said, hey, you can charge a much higher price point and then give people a discount based on who they are. This employer gets a big discount, this insurance company gets a discount. And it started this game of dialing up the price and also dialing up the discount, but not quite as much as you dial up the price. So if you dial up your prices 10% and then tell everyone we're going to give you an added 8% discount, you just made $2 million for the hospital. Congratulations, Joe. Now you're the CFO. We're going to give you all this promotion. And so the hospital started hiring armies of lawyers and staff to negotiate these contracts. And the doctors were in the background saying...
Who are they negotiating with? The insurance companies?
Insurance companies and a bit with employer groups.
Yeah.
And so the doctors are in the background watching all this saying, hey, what's going on over there? We have a whole new building. What are these people doing in there? They're not delivering patient care. Now, I'm not saying they're bad people. They're doing exactly what the system is designed to do, and that is feed off of this middleman industry. And then on top of that, you have no quality measures, right? So you're really flying blind. So then became the mass crusade to advertise on the NFL stadiums and all over the world to say, hey, we are the great fill-in-the-blank brand. Come to us. We use a robot. We have a helicopter. And then there was this perception that we have to include this big brand in our insurance network. And then they would then just dial up the prices and take people for a ride.
This is what's really hard about this subject is there's multiple things that happened over time that are very difficult to dial back. There's maybe the answer is in the book, but but it's hard to distill that into legislation, feasible, and let alone feasible legislation that dials back our system also in a responsible and methodical way that doesn't break it right away. Yeah. I mean, because this stuff happened over time, and because well before that was the incentive for employers to offer insurance, right? Because of wage controls during World War II. So that's the history of why most insurance is done through the employer in the first place. And we find ourselves here over time, and talk to us about Obamacare then. Like, how did that change the system even more? What's the layman's view of that?
Well, at one point, healthcare was polling as the number one issue in America. Mm-hmm. And the irony is healthcare is more expensive now than it was then.
Right.
And now it's not even close.
It doesn't poll. I don't get that either. But yeah, back then that seemed to be the case. I wonder why.
It's ironic.
I mean, it's important, obviously. Maybe it should pull up there, but
it's like twice as expensive as when it was polling number one. So the frustration led people to say, let's address the two giant issues that are burdening every business and family in America. Number one is we have a large group of uninsured people. There were 44 million at the time, and people had a heart for those people, and they wanted to see them get coverage. The second problem was the rate of increase of prices in healthcare was unsustainable.
Right.
So the Affordable Care Act tried to address both of these problems. They took the number of uninsured down from 44 million to about 25 million. And on the price point, healthcare is about double the price so it failed. I mean, any objective measure, it failed on lowering the prices. Now,
and how did it even get 44 to 25? Let's explain that to
massive
people.
Subsidies, massive
Is it
government
mostly
subsidies.
through Medicaid expansion?
That was a part of it for sure. Medicare expansion, and roughly half the states in the country, and now it's the vast majority. But it was creating insurance plans on an open exchange network that people could pick that were heavily subsidized.
Right.
So of course they would take people that are sicker than your general health insurance plan that you have to climb out 3 flights of stairs to sign up for, because that was sort of a screening test of who's healthy.
Sure.
Or you have to use their app, which is going to select younger, healthier people.
Yeah.
So the sicker people tended to go on these exchanges,
right? And
they're just massively subsidized. Now, we spend so much money on healthcare. I would submit to you, we spend half of federal spending on healthcare in its many hidden forms. It's not just Medicare and Medicaid. That's almost a quarter of spending, depending on the money that comes back from the states to the states from the FMAP program. Social Security is like, a quarter of all federal spending? Half of those Social Security checks are going to healthcare expenses, co-pays, deductibles, non-covered services, and coinsurance.
Is it because it's SSDI, the disability insurance? Is that what you mean by that, or is there a different? Are you saying Social Security checks literally are what seniors use to pay their co-pays?
That's right.
That's what you mean.
That's right. Yeah, that was a Kaiser study. And then the Defense Department has its own healthcare system. They got their own med schools and hospitals and insurance program like Medicare. It's called TRICARE.
Yeah.
And then
that's what I'm on. Yeah.
Okay, you're on TRICARE. And then the VA system is separate. That's almost like 5% of federal spending. And then interest on the debt is in part interest on healthcare spending. And then we pay for health insurance for 9 million federal workers.
Yeah, no, you're easily right. It's probably 50%.
50% of federal spending is on health. So what do? Go to 80%, 90%? Do we cancel all other national priorities?
Well, this debt ceiling debate last week, I was like, guys, people were like, well, if we just stopped spending, we wouldn't have to have this debate. Right. And I was like, all right, tell you what, abolish the entire federal government, except for all the programs you won't abolish, right? Which you know what they are, and all entitlements. So abolish the CIA, abolish the FBI, abolish the Department of Energy, and the Department of Education, and the CDC, abolish all of it. You still will have to raise the debt ceiling probably next year.
Wow.
Because that's 11%. Non-defense discretionary is 11% of the total budget. That was like that was a pretty eye-opening statistic when we were having that debate last week, and 70% is entitlements, and it's easy to. You might be even wrong. It might be more than 50%.
Well, during COVID, it was
for health, but yeah, it's massive, and nobody wants to touch that. Nobody, not conservatives. Well, there's the real conservatives definitely do, but it's like we all got to do it together, and just walk into the firing line. It has to be addressed.
Well, thank you, first of all, for having that debate. I mean, those are the real issues. There's broad consensus in America on a lot of things. A lot of the stuff they're not real issues, right? They're dangled in front of us on the echo chamber. These are real issues where there's broad consensus. I mean, what are we doing? But the healthcare spending is completely.
There's broad fear of dealing with it. And also I think broad ignorance of how to deal with it. So why we're doing this podcast. We're going to solve it all within an hour. All right. But so I think we've outlined some of the problem, but I mean, let's go into more specifics on like where does the problem even start? Is it price transparency? Is it the way these hospitals have congregated because of Obamacare? I mean, are they all equal problems that we have to deal with separately?
Well, first of all, you bring up a good point on the mass consolidation of hospitals is driving monopoly pricing, and that was driven in part by all the regulations that made hospitals and independent physicians practices say, hey, the only way I can comply with all this regulatory stuff is to just join up.
Yeah, because they've got a compliance team on the 15th floor, and they'll deal with it. Right? I mean, that makes sense if you're just a doctor with a practice.
And you have to sign up with an electronic health record, and who's going to launch a massive IT implementation in your little practice? No, people were retiring early. They're just saying, I'm not going to sign in. Here's my retirement notice. Mm-hmm. So they folded in. We got monopoly pricing in some markets. But we also, I was a part of this effort to get the price transparency executive order signed in the last administration. Right. And only about 15% of hospitals are complying, but there you have what could actually ignite some competitive marketplaces. And as third-party and app and tech guys are starting to scrape this data to make it available to you so you can use it to navigate where to go, there's a lot of promise with price transparency.
AI, find me the best price for X. I mean, that can't be that far off, right? You can write us poems.
That's right. Yeah, it's coming. It's coming. And then we're working on quality metrics too that actually measure the appropriateness of care.
It's just difficult for policymakers to know where to start, and I'm not sure there's not a great vision up here for where that change can go. I mean, like the far left has their Medicare for all. Luckily, that's still not a super serious conversation in the mainstream. Luckily, and I'm constantly trying to get Republicans to come up with our plan, right? That we can name, that we can label, that we can market. That's what politics is now. But the devil's in the details. And my personal take is we've got to enter the healthcare policy debate the same place that a patient enters healthcare system, which is primary care. I think you got to wrap your arms around something solvable. And because what we tend to do is we get distracted. Okay, it's price transparency over here. It's hospital consolidation over here. It's PBMs. Nobody knows how the hell do we even explain what PBMs do.
Right.
I certainly don't. I get taught it and I immediately forget it because it's so freaking complicated.
Yeah.
For anyone listening, those pharmacy benefit managers, those are the ones who buy drugs from manufacturers and have a very complicated pricing mechanism to get them eventually to you. They're supposed to save you money, but they make billions somehow. So tracking that money is very suspicious and difficult. But on the primary care side, one thing is because med school has gotten so expensive. I have a question as to why it's gotten so expensive. But maybe the same reason all universities have gotten more expensive. I don't know. Maybe you have an answer for that. But it's forced people into specialties. It's probably better to be you, right? You're a pancreatic surgeon. I'm assuming that's a much more lucrative job than being a primary care physician. But we have serious issues with shortages of primary care physicians.
Yeah, and it's changing. Primary care is becoming attractive again right now.
That's
and
good.
More people are going into it, in part because the market is realizing that if you have a primary care doctor doing all the steering of patients to specialists, that's job is a money job. Mm-hmm. And so there are a lot of these direct primary care clinics. A lot of employers are saying now, hey, we want to do our own steering. We don't want to have people just randomly walk into an OB's practice where the OB has a 90% C-section rate. We want somebody who can steer and use metrics to steer. So primary care docs are coming out of med school now making $230,000. We've never seen that before. They were making half. Yeah, they were making half when I came out of med school. So it's becoming more attractive. And that's good. That's good for the field. The problem with primary care is the field has not even figured out its own best practices yet. You still have people saying avoid fat. If you walk in and you're overweight, you'll hear 5 different things from 5 different docs.
How is that possible on nutrition? That drives me crazy.
Well, the food industry controlled a lot of the messaging, the field of nutrition.
Yeah, I did a whole podcast on that.
Oh, really?
A month or two ago. It's nuts. But it's nuts to me how anyone, especially a doctor, still buys it. I'm not a doctor, and it's very easy for me to understand what nutrition works and what doesn't. I don't know. I mean, just coming from maybe that's coming from the military, where we're constantly, it's like being on an elite sports team. And so it's obvious to us what's real and what isn't as far as nutrition goes, but I just don't understand.
Well, nutrition had an Anthony Fauci in the 1960s. His name was Dr. Ansel Keys.
Really?
Slick, smooth, and with really shoddy data. I mean, almost fraudulent data, but very, very shoddy data that he published on epidemiology and low-fat and high-fat diets, leaving out a bunch of countries and just drawing lines where they fit his hypothesis. He convinced the world slowly over time. There was a lot of dissent in the medical establishment, letters in the New England Journal of Medicine into the late 1970s saying, hey, what are we doing recommending a low-fat diet? This is crazy. We don't have data. This is an experiment where the government's recommending a low-fat diet. This is a nutritional experiment with no data. And there was a lot of dissent. But what happened was the medical establishment, the American Heart Association, signed on to this idea of the low-fat diet and made millions of dollars licensing out their little heart to every mom and pop restaurant.
Oh,
and so that became the dogma. That was this sort of, let's all ignore natural immunity together of the day back then.
Yeah. Well, it's ridiculous in it, but if it's still going on, I mean, like I said, I already did a whole podcast, so I don't want to dive too much into it. But it was, it stemmed from this like ridiculous study that Tufts University was involved in, my alma mater.
The food companies.
Yeah, where like Lucky Charms are better for you than red meat, and it's just like, how do you think that? I just want to go back to. We're going to solve the whole problem today. So Obamacare comes.
Yep. So
this is the history of healthcare pricing. Obamacare comes. You get more people covered via a combination of this of the ACA website, the marketplace, with the gold and platinum and silver plans or whatever it is. And but I think most of it was Medicaid expansion. Am I wrong about that?
A lot of it.
At least a good part of it. They did that by simply raising the poverty level by which made you eligible for it. How exactly did that raise healthcare costs? And then I guess the next question obviously would be, what should we have done instead to both give people what they need, which is healthcare. I wouldn't call it a right. I don't like when people call it a right, because a right assumes that you're basically conscripted to my service as a doctor, and I think that's a weird thing. But it is something we need, just like food, just like shelter. So how did that raise prices, and like what are the mechanisms that cause that, and then what should we have done?
It failed to address the price inflation of healthcare. So it just completely failed to address it. So it was in motion before the Affordable Care Act, where prices were jumping up, and it claimed to do things that were going to finally tackle price inflation, and it completely failed in that job. And the reason is that the big issues driving up prices were completely unaddressed. Low value care, that is us doing stuff as doctors you don't need.
Right.
The best way to lower drug prices in America is to stop taking drugs you don't need. Yeah. We prescribed 2.4 billion prescriptions 10 years ago. Last year was about 5 billion. Did disease really double in the last 10 years? No. We want to pop a pill for everything. Opioids was one little window into our massive overprescribing problem. And it's more than just that one drug, trust me. And so we have all of these problems growing and rampant, and this cozy relationship between pharma and physicians and regulators. Yeah. And we have a lot of issues that can be addressed that were not addressed. And one of them is the PBMs that you mentioned, the pharmacy benefit managers, group purchasing organizations. Many of these solutions, ironically, can be enacted today, not on a government basis, but by individual businesses in America buying insurance in a smarter way. And they generally don't do it. Most businesses are getting ripped off on their health insurance in the order of 20 to 40%.
Yeah. And can you blame them? Because I have no idea how I would even shop. And I'm on the healthcare subcommittee in Congress. Like I kind of understand the issue, and I still don't know. If I were running a small business, I have no idea how I'm supposed to shop for the right health insurance.
Well, there's a smoke screen, and in that smoke cloud, you are sort of dumbfounded. So you basically say, I need a broker to guide me through the process.
And who pays that broker?
And the broker is getting paid on the back end and the front end. Now, some of it's disclosed and some's not, but there is so much money being made in that middleman industry. So a group of doctors and I are actually going to be starting a new health insurance plan for self-funded insurers. Just a pure doctor, streamlined, clean plan that'll come in way below what the price is of other plans. And I actually think if the government does nothing on healthcare, the private sector can fix the problem.
Yeah, well, there's a lot of interesting innovations at the private sector level. And again, like from our level, it's still not obvious how to fix it. As you said, what it didn't address, the basic mechanisms which cause price inflation. And I tell people all the time, the only things that do bring prices down, the only forces, are some sort of competition, and well, that's pretty much it. You have to have some sort of competition, and without that mechanism, there's another element that I think I'm missing when I usually make that comment, but it didn't even come close to that, right? It kind of dealt with it the way we deal with increasing prices, increasing tuition prices at universities. Just give more people money to buy the thing that they need to buy.
That's right.
Which is essentially what Obamacare expansion is. But there still has to be a thing to buy. Now, in the university setting, at least there's plenty of universities. It doesn't seem to be a shortage of places to go. That's not going to be true in the healthcare system. Eventually you get that piece of paper that says you have insurance. Well, but it doesn't work all the time. It doesn't guarantee you access to a doctor. That's kind of a big deal. So maybe can you talk about that and like that disconnect in the healthcare sector?
Well, the Obamacare legislation changed the way we finance healthcare, but it did not fix healthcare. We need to talk about not just how to pay for healthcare, but how to fix healthcare. So, to actually get at these root problems, we've got to think about, are we going to throw good money after bad into a system that's broken, littered with middlemen, repricing, markups on drugs and devices? Things are coming to market faster than we can study them, and people are getting all sorts of medical intervention with no data. Just look at the COVID booster in young people, right? The government just buys 171 million doses of the bivalent vaccine just last fall. No randomized controlled trial. Pfizer made $100 million. They can afford, $100 billion. They can afford to run a randomized controlled trial.
Yeah.
And so that is a symptom of a larger problem in medicine. Low value care that we finance good money after bad into a broken system. So you can say, look, we need more money. We got to throw more money into the system. Sure, you're financing healthcare, but you're not fixing it.
Well, and one of the problems is, a lot of doctors won't take Medicaid because it underpays. They don't even like taking Medicare because it, in theory, underpays by what people say maybe 60% on the dollar of what their actual costs are. So it's kind of funny when hospitals say that, because I'm like, so you do know your costs, because they fight the price transparency legislation that actually just passed out of ENC in a bipartisan way. So, that Trump administration stuff you guys worked on, we're trying to codify that into law. Hospitals are not happy about it, but look, I mean, it's got to get done. But talk about that dynamic from the doctor's point of view, and how you have to weigh all of these different financing mechanisms. The Medicare, the Medicaid, which underpays, and how that affects a regular person who has regular insurance versus somebody who's just paying out of pocket.
So the hospitals claim that they lose money on Medicare and Medicaid patients, so they have to overcharge the private commercially insured patients. there's a fair amount of debate as to whether or not that's actually correct, because there are hospitals that take, by and large, Medicare patients. The vast majority are government patients, and they are profitable. So either those hospitals have really lean management and good administration and are doing good care, or the other hospitals are bloated and are using money for 5 deans of diversity and everything else. So in my book, The Price We Pay, I highlight a hospital in Nebraska that's making a lot of money, doing really well, taking mostly Medicare. So that begs the question, is Medicare really a money loser? Well, I do think if it's not already a money loser, it's becoming a money loser, and because Medicare cannot keep up with inflation. And this is true with every government in the world. Any government that has government sponsored healthcare cannot keep up. It sounds great early on. You're going to cut the middlemen out. The government's just going to pay directly.
Sounds super simple.
Sounds great. 10, 20 years, 50 years. 100% of the time, governments underfund and squeeze the belt. I mean, Medicare's doing it right now. NHS does it. Canada does it. Everyone does it down the road. Yeah. So that's the problem.
It's a price control. It's a price control mechanism, and in any market, doesn't matter what the market is, that constricts supply. Mm-hmm. That's kind of a big deal when you're talking about healthcare, because supply. When we say supply in healthcare, we mean number of doctors, number of facilities, amount of money going to research and development. That's a big deal, and you just get less of everything. If you have less of a selection in a certain market, it's not life-threatening, but in this market it kind of is. So it's dangerous. So then what would we say if we were designing a new society right now from the ground up? How would you design a healthcare system? What would be the proper way to do it, right? With a couple assumptions in mind, which is, one, healthcare is something you need. We're going to stand by this idea that everybody should have access to a doctor in some way, shape, or form. That it's a human right. I think we already stand by that idea, because by law, if I go to your emergency room, you have to treat me. So, assuming that's true, what's the best way to design a healthcare system? Another assumption is that it's innovative, that it's constantly improving quality of care, and that it's profitable for everyone involved. So first of all, I love being a doctor, and most doctors do the right thing, or always try to. But if I could create a perfect healthcare system, I would remove the perverse, extreme financial incentives just to do more stuff without doing quality stuff. We don't have good quality measures. When you shop for care, you should be able to know roughly the quality of that doctor and the price of that doctor, and not the price of the steering wheel and the brake pad and the tire. And nobody shops like that. You want a bundle. You want a price for the whole product. Mm-hmm. And so we got to get away from a code for every little thing we do and say, you're pregnant, we will take care of you for $10,000. Just like an airline is going to fly you if the plane has an emergency landing or has to divert, or the fuel costs are 3 times as high. You build it into the model and you make patient, simple, understandable bundles, and we have competition around. And some people check multiple bags. Some people's some people's has a 10-pound bag versus a 50-pound bag. It's the same price.
Yeah, that's right.
And they were right. They just put it in the algorithm. It's not a terrible analogy.
I mean, if you have massive extreme comorbidities, there could be an adjustment. But right now, it's crazy. The coding game is burning out the doctors. The hospitals spend all this money playing the coding game.
But I mean, go even more basic than that. Would you have insurance companies in your perfect utopia?
I think there's a role for money being put aside for a rainy day when you get sick. Kind
of like a catastrophic care sort of fund.
Yeah.
So again, we're talking about utopia now. Because I think the only way we get to a better healthcare system and message that to people is if we explain it to our constituents in terms of a utopia, right? Now it'll take 50 years for us to get there, but at least I tell you what our vision is. This is what Republicans lack, very, very badly lack. Democrats have it. Their utopia is Medicare for all, and it's really easy to understand. Mm-hmm. We don't have an easy to understand utopia. So in this utopia, is it how do you pay for catastrophic care? Is it through a reinsurance program? Is it like a kind of a, whatever that rainy day fund? I'm blanking on the term for what we call a fund.
High risk pools.
High risk pools. Yeah. What is it? Again, you can design anything you want. Like how would you start? You got 100 people in your new society. Like how would we do it?
Yeah. I mean, I like the idea of a minimum coverage requirement. So insurance company can't pull a fast one and say, well, we cover everything, but not type B lymphoma, where, too bad for you. You didn't read the fine print.
Yeah.
Those gotcha games have been outlawed already, and that's probably a good thing.
Okay.
And then you have basic insurance plans, but you have competition at the level of price and quality. We have competition in healthcare today, but it's at the level of valet parking and billboards and signs at the NFL game. We need competition at the level of price and quality of the service. If you are going to deliver a baby in New York City, the price of delivering that baby ranges from $5,000 to $71,000 for the exact same service.
And like even in the same hospital?
No, in different hospitals in the New York City region.
But there's no difference.
There's no difference in quality. I mean, in Boston, the range is $6,000 to $31,000, and those two extremes are both at Harvard affiliate hospitals. There's no difference in quality. So if you're an employer, if you're a patient, do you want to go to the $70,000 place or this $4,000 place? You want to go to the place with the best quality. And if it's more expensive, you'll pay for it. But right now you're flying blind. And it turns out in all the research that's been done, and I go through it in the price we pay, the more expensive hospitals tend to be the lower value hospitals.
Yeah.
And the best surgeons in the world are sometimes operating at the most median or average or below average price points.
Okay. But again, how do we fix that? Like, how do we, so how do you fix, is that price transparency issues?
Price transparency.
So forcing them to post prices is the first thing, but then measuring quality, that's still complicated. So, I mean, only way to measure quality is outcomes. I mean, hospitals have reputations, doctors have reputations. And so as patients, we kind of get a sense for that, but is there a better way? Is there a more obvious way to measure that?
The field of quality measurement in medicine has been stagnant for like 30 years. It's been frustrating. All the healthcare experts make it sound like we're right around the corner from being able to measure quality. Well, they're not, okay? They have painted themselves into a corner with such elite criteria for quality measures, and the associations, which are trade associations of doctors, have to approve it. Well, nobody wants to approve measures on how you're going to be paid and evaluated. So what we've done at Johns Hopkins is created a new generation of quality measures that looks at the appropriateness of care. How often during spine surgery are you as a spine surgeon putting in hardware, screws and plates in the back? It should never be at a rate greater than 50% of your non-deformity, non-trauma, non-cancer patients. We can measure now the appropriateness of care. We can measure C-section rates. We can measure how many times during a colonoscopy a doctor does a biopsy. Biopsies are important and can save lives, but not in 100% of your colonoscopies. We can measure these patterns. We can measure them in the Medicare data set, and we're doing it. So that is our work called global appropriateness measures that we're doing nationwide. And the attempt is to come up with meaningful measures of quality, because that is what we have to do in healthcare, is measure quality and price.
All right. So again, going back to the perfect world, price transparency is it's perfectly transparent. It's easy to find. That seems feasible. There's some kind of quality measure. I think it'll always be imperfect when you're talking about healthcare. It's got to be.
That's right.
Because at the same time, even what you're talking about, the first thing that I'm sure you hear it from doctors is like I'm the doctor. I know what I'm doing. Like, you don't need to be looking over my shoulder and looking at my data. And 50%, 45% makes me a bad. 51% makes me a bad doctor. 49% makes me a good doctor.
Right.
I'm sure that's what you hear back, and because it's hard to measure quality.
Yes.
But again, so there'd be an insurance company, but they'd have to cover everything. No hidden gimmicks. Like you said, that's widely agreed upon, I think, is now anyway. What about the deductible system, and how How should you shop for insurance? How should you pull people into insurance? So Democrats, when they were pushing Obamacare, I mean, their logic is, if everybody, this is why they wanted to tax people who didn't have a health insurance plan, because the logic went that if everybody was paying into it, it would lower everyone's price.
That's right. Now,
that's not incorrect logic.
Yeah.
That is technically how insurance works, right? You have to have car insurance. So that's why it works. Now, of course, you run into a problem with just basic personal liberties, and which is where it all fell apart and why that tax went away. But what is the right solution then?
Yeah. Yeah, and that promise was by and large a broken promise. The idea that if you remember, and I'm not speaking as a partisan in any way, but if you remember when Obama ran for office for president the first time, his campaign speech and one of his stump points everywhere he went was that I'm going to lower the price of your health insurance by 20+%. And audiences loved it.
Yep.
And it was a great message. And I love it. I love the idea. It never happened. It went the other direction.
Yeah.
Right. And the problem was they just didn't recognize the other drivers of healthcare inflation.
Yeah.
I mean, also, there's this myth out there that if we do more mammograms, if we do more colonoscopies, we're going to lower the price of healthcare. Well, those services cost money. And while I support those interventions, how about school lunch programs instead of just all the money we're spending on bariatric surgery and Ozempic? How about communities for kids so they're not on 5 anxiety medications and depression medications? How about treating more back pain with ice and physical therapy instead of just surgery and opioids? How about treating people with high blood pressure by talking about their sleep? Because sleep medicine is very mature now. Instead, we're just throwing antihypertensives at people. So when somebody comes in to see us who has diabetes, we should be putting them in cooking classes, not just throwing insulin at them.
Well, I agree with all that, but that all gets it. I can't change any of that policy. That's like in the medical. That's a medical profession.
You're saying as a legislator.
Yeah, I mean that's the medical profession that has to get to a point where you're giving people the right treatment and not telling them that Lucky Charms are more healthy than steak. Right? It's that's basically what you're telling me, and I agree with all that. But I can't we could outlaw sugary snacks out of the SNAP program. There's serious discussions about that.
That's right.
I'd probably be okay with it. I mean, it's bring back fat shaming. I mean, bring it back. It's because it's honestly, if you care about somebody, you got to tell them the truth. But I want to focus on the pricing and the financing and utopia, because I can't get this Congress to a solution until we understand where we're trying to go.
That's right.
You got to know what the end looks like. And so what is insurance for? Should it only be like car insurance, right? Do we have to get to that point? And then what about the people who can't pay for the tire change? So my car insurance doesn't pay for me to get new tires. It's just not what it's designed for. It's only for wrecks, and car insurance works as a market. And is that what we have to do with healthcare? And what is the tire change? Is that your primary care doctor? Is this where direct primary care comes in? And then do we subsidize that? Do we have a debit card? Does everybody have a health savings account that funds, whether it's their insurance or their direct primary care doctor? All the money flows through one account. And if you're in need, you get it subsidized, but then you go on the open market and do it. Is that a better system?
I'll tell you the most exciting thing I've seen is you get to see the price and the very immature quality scores on every doctor or medical center. And you get an allotted amount for whatever it is, for a medication or for a visit, for a consultation or for a procedure. There's an allotted amount that is what you're entitled to. If you select a provider below that allotted amount, you get a check for the difference. If you go to a place above the allotted amount, you are on the hook. And so some groups, including this one group that I advise called Sidecar Health, is basically gives you they're doing amazing stuff. They give you a Visa card.
Yep.
And they're like, this is your allowed amount at the different places. It's on the app. You can look, go wherever you want. You can go wherever you want. But if you go below the allotted amount somewhere, you're going to get a check for the difference. If you go above, you're on the hook. It's going to be billed to your Visa card.
It's like rollover minutes.
it's great. It's like rollover minutes, and things were going great until CMS basically blocked them from going on the exchange, CMS, Center for Medicare and Medicaid Services, and said, you don't have a network, and that could be confusing to patients. Well, that's the whole point. The point is to get rid of networks. Why do you need a network?
The network is, by definition, confusing to patients.
The network is the arsonist and the firefighter. It's the problem, and it's the solution there to create the problem it creates.
Right.
Why do we need networks if you had an open market of prices and quality?
Yeah, and it's like the one thing I'm okay with on the Obamacare thing is a website where you see all the insurance plans. So that's like step one. And that already exists for direct primary care. You can type in your zip code, find your direct primary care doctor. But that should be normalized. You should be able to go to an app just like you shop for your airline tickets and compare and contrast. And so obviously I keep trying to like push us towards the utopia that I push or that I want, but I just want to test it against you and see if you disagree. I mean, that's kind of the point of this. So, I categorize it in three ways. Healthcare generally, right? You've got primary care, you've got broken bones, you got like care that's not exactly primary, but it ain't exactly cancer. Okay, so it's a broken bone. It's a sickness that can be resolved within whatever a given period of time with treatment. I don't know.
Semi-elective.
Sure. Yeah. I'm sure there's like a smart person term for this, but I call it phase 2. Okay. And then there's the catastrophic care. Like this is the big stuff. This is the stuff that costs $100,000. You're hospitalized for weeks at a time. That's a really big bill. My theory has always been insurance should have nothing to do with phase 1 or phase 2. It should only be number 2. All right. 1 should be paid for by you. And if you can't pay for that, well, because we're talking primary care. That's as well as I do, $75 a month will get you a direct primary care subscription these days. That's pretty good. Most people's, that's less than a gym membership. It's less than your cell phone bill. And if you really can't afford it, maybe that's where a Medicaid program or some kind of pilot program, that's what I'm actually trying to figure out, comes into play. And that goes on your debit card that you pay. And then if you want to find the primary care doctor you like, you get $75, but maybe you want to pay $85 because that guy went to Harvard. Okay, well then you pay the extra $10. This isn't that complicated. This is easily doable. Insurance should do that second part, and the third part, that's what we have to figure out. Because if you make insurance do the third part, which is what we do now, what do? They raise everybody's premiums astronomically in order to cover those patients, right? That 10% of the patient population that accounts for like 80% of the cost. And so you look at these numbers and you're like, there's just got to be a better way. Again, if you were crafting a solution right from the beginning, got to be a better way to do this.
I like the way you think, and I agree with you that it needs this whole concept that we're talking about needs a good name, right? Because Medicare for all.
I don't know what the name is yet. I've been trying to figure it out for 2 years.
An open market of shopping for price and quality, it doesn't resonate with people, right?
It doesn't. It sounds like you're just going to you're going to rip the rug out from under them.
That's right.
Anytime you use things like open market, whatever, it feels like you're going to rip the rug. That, repeal and replace, that was the worst term you could ever think of.
Yes, and we don't have a replacement, but
right.
It's going to, exactly. Yeah, so look, I get it.
But it's like, I don't know, patient-centered care. I know it's called a premium. We're talking about premium support models is what we're talking about, but that doesn't make sense to people either. It's not obvious what the name of it is, but we haven't even decided that that's our utopia. That's right. This is why I test this amongst like kind of experts like yourself to make sure that, is this even with the direction we want to go? Can we agree on that?
I tend to focus on what's feasible politically, because there's a saying in Washington that you can't do anything unless all 4 healthcare stakeholders are on board. Mm-hmm. Pharma, AHIP, which is the insurance lobby, American Medical Association, and the American Hospital Association. Those are the 4 big boys. And sure enough, when we got the Affordable Care Act, all 4 signed off. And so I tend to think about what can we change. For example, the employer-sponsored healthcare, the fact that your employer covers your healthcare or part of it, and then you're afraid to leave jobs because you might lose energy.
Right.
That system makes no sense at all, but it's what we inherited, right? It's what we inherited from the World War II time, like you alluded to. So I tend to think, what can we do that's feasible? And I tend to think that employers can be proxy shoppers of healthcare. So even though you don't care which doctor is going to charge $71,000 to deliver your baby or $6,000 for the same procedure, your employer may care, and they can give you a stake in the game. They can reward you if you go to the docs that does it for $6,000. You're not going to pay anything. Either way, you can go anywhere. You got freedom. But if you go to the doc that's going to charge $6,000, we will give you diapers and wipes for a year. That's what one employer did in Boston. You create a way to partner with them to convert a non-competitive market to a competitive market.
Right.
Then the hospital that's charging $71,000 says, hey, where's the business going? We're not seeing the patients. Well, you guys are charging $71,000. And so those are the creative solutions I think we can do. But we don't need networks.
Yeah. Well, what do you do? Do you outlaw networks?
No.
How do we deal with that in Congress?
Well, the idea of here's a pre-selected, curated group of doctors or hospitals is essentially like a preferred network, if you will.
Yeah.
But the idea of the network was the reason why this idea of the Visa card being your insurance card was blocked by Medicare. So what can Congress do? I think a lot about this question. What can Congress do? I honestly think a lot of the big healthcare reform is going to happen with the private sector, employers choosing to buy their healthcare differently. Choose a health plan that is going to create these creative incentives for your patients to go to the $6,000 doctors. And guess what? You're paying less money as an employer because you're covering 80 to 90% of all healthcare costs. So we're starting to see movement in that sector.
Yeah. I agree. I mean, I don't disagree with your logic either. I mean, the reason I harp on the utopia is one, because I'm a politician. I have to explain this to people.
That's right.
And their eyes glaze over when you start going into the details about price transparency.
Right.
And, I mean, it's just, but I totally agree that when I say, look, we have to at least establish a utopia, like an end game that we'd love to get to. But then also the next sentence should be, look, it'll take 30 years to get there if I were a dictator. And that's if I were a dictator, because that's how slow that process would be. And it's the other reason I said, look, you do have to have these entry points, which is, I mean, my entry point is just making it slightly easier for direct primary care to be a thing. Yeah. For instance, allowing health savings accounts to even pay for a direct primary care doctor. Like, that's step one. So it's very, very discrete, definable steps that should be easier, and even those are difficult.
What do you think about this? And this is an honest question in terms of a solution that can be messaged. To fix healthcare, we need to all agree to get rid of secret prices and to get rid of kickbacks.
There's pretty good agreement on that. I mean, that was just what we've been working on in E&C. Pretty wide agreement on price transparency at this point. Pretty wide agreement from hospitals that don't like it. And our answer is, we could be a lot meaner to you guys, I think, than price transparency. This is just something you're going to have to deal with. And everybody's mad at PBMs and the kickbacks. So
a lot of kickbacks.
Yeah, a lot of that. So there is some good agreement on that.
Yeah. I mean, half of the price of some of these drugs, it goes to the kickback.
Can you explain PBMs in a way that a normal person can understand and how that pricing mechanism works?
So think of it as you've got a business and someone comes and says, we're going to set up a Girl Scout cookie stand. Right now, your employers are getting it on their own, and we're just going to take care of it for you because you've told your employees you're going to pay for the Girl Scout cookies. So rather than have them go out there and buy them and bring in the receipts and you administer the claims and process, we're going to take care of it for you. We're going to set up a nice Girl Scout cookie stand. Okay. So what happens is the person who says that says, I want $1,000 to manage that Girl Scout cookie benefit for you.
Right. That makes sense. A fee of some sorts to make it easier on you.
Yep. Sounds good. And they say, hey, we're going to be independent and we buy Girl Scout cookies in bulk. Okay, Sounds very attractive. Then you find out they're paying the Girl Scouts $1.50 an hour. And you find out they're paying the Girl Scout cookie, the Girl Scouts for the box, Instead of the standard $6, they're paying them $2. And you're like, whoa, where's all this money going? Oh, well, we're giving you a discount. We buy in bulk and look at how we're managing the operations for you. And we're going to give you a full transparency printout of all of our finances. But with drugs, you can't understand it as an employer because you get 1,000 names of different drugs with different biosimilars and frequencies and doses. And you see these names and prices. You don't know what the base price is. Girl Scout cookies, you know you're getting ripped off. Drugs, you have no idea. Do you know 90% of drugs cost less than $20 a month? And yet people are getting gouged. And what they do by, say, charging the employer far more than what they pay for the drug is called spread pricing.
Yeah.
And so they're paid to manage the benefit, and then they gouge them on the spread. And hospitals are in on it too with the drugs and chemo that they infuse in the hospital. And the devices, they charge a markup. The differences with PBMs is the pharma companies will say, hey, we want in your list of drugs that you offer something called a formulary. In other words, we want you to sell our cookies alongside the Girl Scout cookies, and our drug costs $50, but I'll tell you what, we'll make it $150, and we're going to give you 100 of it. Yeah. That's a rebate. And the middlemen might give 10% of that rebate onto the employer and say, oh, look, we're getting you free money because we bulk it. Well, you've kept 90% of that rebate, and it's a giant scam, and this is the stuff that employers cannot. And
it keeps going because somehow everybody is a little better off. Like the employer's a little bit bright, but not the patient. That's and then although are the manufacturers better off here? They're kind of equal. They don't really. It doesn't seem like they benefit or get hurt.
They're kind of agnostic. They're neutral because they're just building in the price of these kickbacks into the products.
Yeah.
Right. You want 100, and sometimes they'll tell you they don't like it. The pharma lobby will tell you we're kind of sick of all these. Putting the gun to our head. The PBMs are putting the gun to our head, saying we want a $500 markup on each drug, and we want that money coming to us. Well, if you're the pharma company, okay, I'll do it, but they make the same amount of money, but they know the game. And
then they get blamed by the public because your drug is too high. Well, it's like it's not actually. You might be blaming the wrong person. You should be blaming the PBMs for that, not necessarily the pharma companies. That's interesting.
And everyone's got a piece of the pie in healthcare right now. Yeah. Everyone's got to look, including us physicians, and see where we can be more efficient and just disarm from this tug of war. The blame game goes around, but you know what? We're all getting rich. Everyone is getting rich in healthcare right now, except for one stakeholder that has no lobbyist, and that is the American worker. And they are financing this giant mess through 50% of federal spending going to healthcare, and then they buy private insurance for $22,000 per household under the illusion that my employer paid for 80 or 90% of that in my paycheck. Well, guess what? That money comes from the pool of wages and benefits. That's your earnings. Yeah. And so they are financing this broken system where everyone is getting rich right now, arguably with the exception of rural hospitals.
So, I mean, if you're advising a mid-sized company on how to do their healthcare, what's their best option?
You got to get a really good consultant, healthcare benefits consultant, one that's going to tell you what they're getting paid on the back end. If they're getting paid on the back end, put it out to bid. Talk to a couple consultants. The consultants can be very territorial. Almost like, drug territory. Yeah. Like, hey, this is my group. I've been with them. The relationships get very cozy, and you're not getting good options as an employee when that relationship's cozy. For example, a consultant, also known as a broker, can come to you and say, your Blue Cross Blue Shield plan's going up 15% this year. I'm sorry. This is terrible. They'll blame everyone. They'll blame Obama. They'll blame drugs. So you had a sick employee last year. They'll blame the world. The reality is the insurer could be telling them, hey, see if they'll fall for a 15% increase.
Yeah, of course. It's kind of like, it feels like a little bit like real estate. It's like, are you sure you're negotiating on my behalf? Because you do benefit if it's higher.
Right. And actually, like real estate, they're getting paid a flat commission based on your total health insurance premium spend. Now, why would a consultant why should they make more if you're spending more on health insurance premiums? It's probably the same amount of work, right? So they could get, and these are good people, by the way, a lot of them, but the system is broken. In New York, it's regulated at 4%. So every year, 4% of your health insurance premium dollars go to that consultant, in addition to what that consultant's getting paid on the back end with a kickback from the insurance company that says, pats them on the back, good job selling our product.
Right.
But unlike a real estate agent where you're paying 3 or some percent once, you're paying your broker every single year.
Right. So there's multiple pieces of legislation on PBMs. I don't think there's any on the broker side, but on PBMs there certainly is. Some of them are anti-kickback.
Good.
Remove spread pricing.
Good.
You like all of those?
Yes.
Yeah. They just crush them.
And they're symptoms of a larger problem. So when you fix one whack-a-mole, they've come up with 5 creative ways to say, well, when it comes to the biologic agents, which are the real expensive drugs, the $60,000, $80,000 infusions like Humira, you've got to use our preferred select vendor that we own.
Yeah.
And they're gouging you on that one. So you're getting a better deal by being more fair on the day-to-day drugs, but they got games. And the bottom line is they're not fiduciaries. I mean, the big PBMs are also pharmacies, like CVS Caremark is a PBM.
Yeah, now they're all vertically integrated. So they're a pharmacy, they're a PBM, and they're an insurance company.
Yep, they're all co-owned. So when you tell your consultant or broker, hey, I'm getting ripped off on this PBM, I want to look at other PBMs, the insurance company who owns that PBM will say, hey, you're getting a preferred rate on our health insurance because you're using our preferred PBM that we own. If you unbundle this, your insurance premium is going to go way up. It's blackmail.
Yeah.
It goes on all the time.
So you need more employers to just kind of band together and be like, call your bluff. Call your bluff. You're not gonna buy. I'll just go to somebody else.
Yeah, but unbundle your services. Talk to more consultants.
Yeah.
There's a lot of ways that employers could save 20, 30% on their healthcare spend.
Yeah. And I've said this a bunch of times on this podcast, but in Houston, and there's a fairly healthy DPC, direct primary care market, and they're it's not so much individuals that they get as their patients. I mean, we're trying to get to that point where it's just, I want to normalize in America that you're in your 20s, maybe you don't want to buy health insurance. I get it. But you should at least have a doctor. Yeah. So do the $75 a month. Have a direct primary care doctor at least, and they can walk you through how you should maybe look at insurance. That's in my ideal utopia. That's how insurance should work. But what they are doing though is they partner with companies, with hundreds of employees, and it works better for everyone. Every employee knows who their doctor is. It's not like because most people don't use healthcare that often. So when they do, they're like, wait, who's my doctor? How do I go to an emergency room? What do I do?
Right.
No, you should have somebody you call.
Yeah.
All right. So it solves that problem. It solves the relationship problem, which I think is lacking. And should be our first priority. But from what I understand, it also allows employers to renegotiate their premiums because an insurance company is looking at this contract and saying, well, that saves us money. So fine, we'll renegotiate your premium and your insurance will now be cheaper because you already have primary care figured out on your own, and it just works better for everyone.
Yeah, I mean, those are things that are good. There are things around the periphery, as I describe it. A lot of times those prices of health insurance premiums are artificial. I mean, if the broker says to the insurance company, hey, I ran the 15% increase by the employer, they're freaking out. They're talking about taking it out to bid. The insurance company could say, well, okay, tell them you got it down to a 10%. I talked to them and I told that insurance guy, I got it down for you. I'm your guy. Yeah. And those are the games right now.
Yep.
So
it requires employers to be more judicious with their spending and more jealous of their own profits, I guess. All right, what did we miss? We've been going on for a while here.
That's impressive.
You want to do COVID? Yeah.
I just see Lori Lightfoot is just got named on the faculty of the Harvard School of Public Health.
No.
Yeah, she's going to join Bill de Blasio, who's already there.
Really?
Yeah. No joke.
Does she even have a healthcare background?
Doesn't matter.
But she doesn't, right? I mean, she definitely doesn't.
No healthcare background except she...
and Bill de Blasio.
Made toddlers mask for 2.5 years.
I don't know what Harvard's thinking there.
fellows. I wouldn't say faculty. They're fellows and
Yeah.
they're teaching.
No, but they did this. I was really pissed off, and they backed down on it. But they added Chelsea Manning as a fellow, Bradley Chelsea Manning as a fellow, and some kind of like national security fellow. And you're like, what the hell does this person know about national security except how to put it at risk? That's the only thing this person knows. And it's not as if this, you could maybe make the case if it was some top general who did it, and there's some kind of there was some deeper reason for it, and it was interesting. But this was just some idiot who was like an E2 or whatever he was at the time. I mean, a nobody, just giving up secrets because they were crazy.
Is that a military rank E2 or is that a blood type?
It's a military rank, okay, and it's one of those, it's about as low as you can get. E1 is the lowest. So if you're enlisted, it's because E1, 2, 3, 4, depending on what branch you're in, it's called something. I mean, in the Navy, it's seaman and then petty officer, third class. But in their case, I think it was sergeant or something. But it's low. It was a low-ranking person. Has no business being a fellow at Harvard. It's done nothing but betray America and then go to jail and then become a woman. So, that's it. But they did rescind that. So that's disappointing. But yeah, so you recently wrote about all of the kind of the myths of COVID and how the data has just destroyed all of these popular talking points that were just considered mainstream, considered the consensus, the scientific consensus, et cetera, et cetera. We'll focus on a couple of these maybe. I mean, some of these are more important. I think the mask one is interesting because that one still keeps going back and forth. But you say it's, as far as the Cochrane reviews go, you consider that the most authoritative independent assessment of evidence in medicine, and we just don't have evidence that masks prevent COVID transmission. So what do you think is the reasoning behind that? Because, I mean, obviously masks are good for something. Doctors wear them.
That's right.
Right? And like doctors who are treating COVID patients would tell me constantly, they're like, obviously we're going to wear a mask treating a COVID patient. Like they do work for us. But why don't they work as just a general public health guidance?
Yeah, so you put two high-quality masks on two people when they interact, say in the hospital when a tuberculosis patient comes to see us, and it reduces transmission. Those studies have been done, and it's clear. The question is, on a population level, if you tell all the kids in a school to wear a mask and you don't specify what kind of mask, are you changing the trajectory of COVID transmission? Those studies have been done. They're very clear. They're out of Europe and all over the different parts of the world, not in the U.S. because we don't allow that kind of research. And they definitively showed it does not change the trajectory of transmission. Kids probably don't wear them. Most of them are wearing cloth masks. And by the way, they've got harm associated with it.
A lot. For kids, yeah.
Yeah.
I mean, I feel like there was harm for me too, but for kids, definitely.
Yeah.
Yeah.
And then, the amount of energy and time and money and political capital we spent arguing masks. And in the end, the study shows the mask mandates had no impact. Looking back, I mean, honestly, we never talked about obesity, the number one common modifiable risk factor for reducing your COVID risk. Never. We never talked about getting outside, right? Be outside.
In fact, in the beginning, they arrest people for being outside in a
Arrested
park.
surfers and put sand on skate parks. And
it was wild.
Michigan closed parks. I mean, people like to politicize COVID. New York did better than California or Florida or what. You cannot do these comparisons because of the chronicity. The waves occurred at different points and the treatments improved over time. However, Michigan and Sweden are the identical population. They got hit with the concurrent waves at the exact same times. They have the same percent of elderly over 65, exact same percent. And in the final analysis, twice as many people died in Michigan from COVID, and they also had a lot of excess mortality. In Sweden, half the number of people died, and they had no excess mortality, and the economy has been thriving. And the number one predictor of health has always been, in every study that's ever been done in the last 50 years, socioeconomic status. When people have more resources, they're healthier. So these were giant blind spots, and you couldn't talk about them because all the studies on masks were all rigged by the CDC. They used their own shoddy data. They'd be out there criticizing hydroxychloroquine for having, an odds ratio that included 1. That's a statistical test that tells you it's not significant. But their own mask studies would have the exact same odds ratio.
Yeah.
Right? And I'm not an advocate of hydroxychloroquine, but
it doesn't hurt either. I think that was what pissed people off. It's like, look, if it doesn't hurt me, then why can't I at least try it? I think that was a thought process. I didn't advocate for it one way or the other, but because I don't know, but
the amount of energy we spent debating those things when people should have been outdoors, the schools should have been open, people should have been losing weight.
Go back to the Michigan-Sweden comparison real quick. So what was the underlying? I think I missed it when you were comparing these two things. What do you think was the underlying difference and why the mortality rate was twice?
Part of it is obesity rates. We know they're a little different.
That's what I thought you said.
But that won't account for double the deaths in Michigan over Sweden. And so part of it is they just had, a more open society, living their lives strong, healthy, and active. Mm-hmm. People gained on average 7 pounds during COVID.
Yeah.
So that was part of it. But why are we not doing this autopsy of actually evaluating the largest public health intervention in history? No one is saying, let's scientifically evaluate whether or not it.
Well, a lot of people are. I mean, you reference studies that actually prove. So, I mean, at least some people are because we're referencing them. But you didn't mention lockdowns in any of these myths. So what do you generally think about that? I mean, I've seen a lot of studies that show that there's really insignificant changes to COVID transmission or mortality rates because of lockdowns. But is that, do you disagree with that?
No, I mentioned in that article on the 10 myths now debunked about COVID that school closures, for example, was one of those things, right? Yeah. We cannot let kids in school because they can get COVID.
Right.
And so when you look at the data was out there in Europe in July 2020 that they had schools open free and clear in Europe, and they had no differences in transmission from the ones that were closed.
Yeah.
Same with masking. I wish the New York Times would have sent one single reporter over there to cover it, or CNN, just to look, the kids first, let me ask you this question. This is, I like to push the field. Has any healthy child ever died of COVID? CDC won't tell us. All the deaths could be in kids with comorbidity. Probably most, the majority, not all.
It's massively small. They're at risk of more at risk for basically everything else in life.
Yeah, right.
Just everything.
Suicide is like
pools,
5
everything.
times,
So, it's almost nothing, and yet that was. Yeah, the school stuff I think is rather obvious. The data is very, very clear, especially for that age group. But I mean, I still wonder about some of the sanity, the thinking behind lockdowns in general. I just want us to. You want to get it right for the next one, and because there's always a next one, and it's a complicated question because it depends on what you mean by lockdowns.
That's right.
Were we locked down in Houston? Kind of. I mean, the gyms and bars were closed. Restaurants maybe were closed for not very long.
I remember.
So is that a lockdown? I mean, kinda.
Sweden basically said nursing homes. We want to try to protect the nursing homes. They did it about 2 months too late, and they've apologized as a government. They feel bad. They feel that they made a mistake. So they were late in protecting nursing homes. But then again, every country was late. And they had restaurants open with some distancing for a few months.
Yeah.
And otherwise, they're pretty much living their lives, sending out the information that if you are older, you have comorbidities, or both, you're at high risk. Be careful.
And that's what I always said to people. I'm like, if you don't want COVID, you don't have to get COVID. Like you are capable as a human being. You can lock yourself down. You can lock yourself down. This is not a crazy thought. Like I never understood the sort of the sanctimonious like pearl clutching of like, you're going to get me COVID. I'm like, you just not be near people. Like it's possible. And if you're that type of person who's so afraid of others, if you were smart, what you would want the most is everyone giving each other COVID out in the world, getting it, being done with it, while you sat at home for a few weeks. Like that would be what you want. Instead what lockdowns do is sort of extend this transmission. Now, there's an argument to be made about hospital capacity. I get that. You don't want everyone getting it at once. And so, I admit this is a very complicated discussion on how you should go about it. But the people who do go out who are kind of fearless tend to be younger, tend to not have serious, reactions to COVID, unless, here and there. But I don't know. It is, as far as morbidity rates go, though, it doesn't. I know the data show, they've done the studies. It doesn't. There's not big differences between states that were harsher on lockdowns, longer on lockdowns, versus states that weren't. And again, you always go back to the Sweden example, but that is a very healthy society just in general.
That's right.
So it does make it more difficult.
California, they were arresting surfers. They, it was completely out of control in California, and people talk about it like, we had to do that for 3 years, and no one's talking about it. NIH, no one's talking about it. My own school, public health, like, we made tragic mistakes. We spread misinformation to the public on COVID as a public health community, and no one's apologizing. The data were clear 2 years ago,
right,
that vaccines didn't stop transmission.
Well, I was kind of furious. I'm not an anti-vaxxer by any stretch. Like, I think holistically, the vaccine is a good thing. Probably saved a lot of old people's lives, but it didn't save my life, and I never thought it would save my damn life. Because I already had COVID. I still can't smell. I'm one of those really tiny people who still have like super long-term issues, but it wasn't that bad at the time.
I remember California, I was going to say, a study showed Stanford students bicycling in Palo Alto, 43% were wearing a mask while bicycling outside, and only 17% were wearing a helmet.
That's funny. There's still people masking. That ain't stopped. All right. It's still happening. But so talk about the vaccine and kind of what's come out about that. I mean, somebody in their 20s or 30s or certainly below, like, I don't know what age, you tell me, like, as a doctor now, what age group would you recommend get a vaccine? And what would you recommend do not get a vaccine?
On COVID?
Yeah.
If you had COVID, there's no data to say.
Let's assume you didn't have COVID, right? Let's assume you've never had COVID, so you have no natural immunity, which we know, based on the data that you pointed out here, is easily, if not more, successful in protecting you from future COVID infections, or from the harm of COVID infections.
That's right. And the harm of the vaccine is, after the second dose, 1 in 6,000 will have myocarditis. And a Swedish study found that 2% of people after a COVID vaccine have some heart injury that's subclinical, manifested with something called an elevated troponin level, which is a blood test that suggests your heart muscle has had some damage. Subclinical, you don't feel anything. 2% of people in the immediate few days after the vaccine had an elevated troponin. So we have not had good research on this, but myocarditis means that for a young, healthy individual, young, healthy person under age 25, if you're healthy, the second dose results in a net public health harm. And the booster results in a net public health harm. And there are many deaths from the vaccine. When I say many, there's a series of a couple out of Germany. There's 8 out of Korea that were just reported. I know of 3 in the United States. That's just me, like through somebody who reached out to me.
And how do they clinically attribute it to the vaccine? How does that work?
So in these cases that I'm describing, like out of Germany and Korea, they've done autopsies where they demonstrate there was myocarditis that led to cardiomyopathy.
Gotcha. Okay, so that's been made clear, and like you said, no apologies. But again, who would you recommend actually takes the vaccine?
I mean, the vaccine downgrades the severity of illness in somebody who is high risk and would benefit from that downgrading.
Right.
And so I've always recommended it for people that are high risk, and if you're very high risk, even if you've had a strain a long time ago, it may make sense. But the idea that you've got circulating antibodies from prior infection and you're pretty healthy and you have to get the vaccine because you have circulating antibodies that neutralize the virus, but they are antibodies the government does not recognize. That is a joke. And that's where the public health officials lost a lot of trust. When we ignored natural immunity, first of all, a lot of people died. Thousands of Americans died from the doctrine that we cannot recognize natural immunity. You say, well, how did people die from it? when we had a limited vaccine supply, we were giving 2 life preservers to some people, 2 doses to some, when we should have given people drowning at least 1 life preserver.
One was fine. Yeah.
One would have saved their life at that time. It was so effective against the strain that was circulating in December through 2020 to April 2021. We could have saved thousands of more lives, but they ignored natural immunity.
Interesting.
And then
I didn't think about it that way.
That's right. We could have saved thousands more lives. And we wrote article after article. I was saying it until I was blue in the face in the media, on TV, in the Wall Street Journal. Why are we giving 2 life preservers to
So
someone?
it should have gone to people with comorbidities and old people. How do you define old? Like at what age, even if they have no comorbidities, at what point does your age become a comorbidity?
Well, 80% of the deaths were in people over 65. We knew that when the vaccine was being distributed. So just go down by age.
Yeah.
Instead of you're category 2C and you get in line here and you get it, just go down by age. That's what the UK did, and they saved more lives, and they spread it out by 3 months. No vaccines given 3 or 4 weeks apart. That's why half of America was in bed for a day. No vaccine is given 3 or 4 weeks apart.
And where did they even come up with this 4-week booster?
So it was with good intentions. They wanted to end the clinical trial early when they were experimenting with the vaccine. It was with good intention. But very quickly, people realized, hey, the protection of the first dose was pretty darn good with the variant that was circulating at the time, 90%. So space it out. And that's what the UK did. Matter of fact, the UK did a formal study comparing a 3-week interval to a 3-month interval. And guess what? At 3 months, they're the same. And you actually had better immunity.
Interesting.
And that's true of all vaccines.
And your point is that with that, if we had known that, or well, we did know it, but if we had not ignored it, you would have been able to use those extra doses for people.
Save lives.
Yeah. Say young people with comorbidities that weren't prioritized. Well, it's not even, I don't even remember how we actually handed them out, to be honest. I think it was whoever wanted them. There wasn't like a system. I think I could have gotten it pretty early if I'd wanted to. I didn't. The only reason I ever got a vaccine was because I had to travel to the UK, like in November of 2021. And I'd already had COVID. I didn't see a need to go get a vaccine. So
the problem was we would talk to public health officials. Many of us had believed in these, the research and the data. We'd be like, hey, there's this amazing data. Let's space out the dosing frequencies. You can reduce the number of myocarditis cases and complications and maybe even deaths. Mm-hmm. And you'd ration better. You'd have lower complications, better immunity. And they would listen to our argument and just Fauci decided this and that's it.
Yeah. It's frustrating. Yeah. I mean, the public health officials, lost a lot of trust, but you can't blame them entirely. I blame politicians a lot more, because it's a public health official's job to say, these are the risks. This is the only thing I look at. So yeah, of course I'm going to tell you how to bring COVID infections down to 0. You lock everyone up. Of course I'm going to tell you that because that's the only thing that person looks at. But a politician is supposed to look at other things, an elected official. So they're supposed to look at, I don't know, how does it affect the economy? How does it affect other health aspects of health? Well, that would also be public health officials' problem. They didn't do that. But there's trade-offs. Everything in policy is about trade-offs, and there's just some elected officials understood those trade-offs and cared about them. Others didn't care and completely destroyed segments of society as a result. And our kids obviously took it the worst, by far. Kids and small businesses. So
yeah, minority and poor populations experienced the absolute worst outcomes of the COVID restrictions.
Yeah,
the wealthy Americans did very well. They're in the country clubs and the suburbs and living life. And so for the public health officials like the CDC director, Rochelle Walensky, whose kids were in a school that was doing great and open and, one of these schools that everyone wants to get into or go to, life was good. People living in their second homes, life was good. But for kids in inner city Baltimore, where I work, who were told, hey, go log on to this iPad, they never logged on and they never showed up in school again. And so with all the talk of, the importance of health equity, these policies were the most destructive policies you could design to exacerbate inequities in the system. I was just at a medical conference, and half of the presentations were on health equity or transgender medicine.
Oh, God.
And I'm like, this is fine, but at some point we have to.
We just banned that in Texas. Pretty excited about that.
Oh, yeah, I heard about that.
Yeah. I mean, I sent a scathing letter to the Texas Children's Hospital, arguably one of the greatest children's hospitals in the world. And I'm like, you're losing credibility by doing this. I mean, there's no science behind this. This is pseudoscience insanity. And they're not doing surgeries. They're like, we're not doing surgeries. I'm like, you're permanently disfiguring the physiology of a child with hormone therapy. Tell me I'm wrong. Is that what hormone therapy does? Does it permanently change the physiology? Yes, it does. I don't need to be a doctor to understand the basics here. Very frustrating. It's and of course it's on the parents for pushing it, but like at least the buck has to stop somewhere. A medical professional has to say no at a certain point, that they'll do no harm. And so what is it? The AMAs condone this stuff. They lost just complete credibility, but what's their, am I correct? Is it the
American
AMA or is
Academy
it?
of Pediatrics.
Maybe it's them. Yeah, it's definitely them. Maybe it's
all of them. They're all
everybody's
signing on
behind
right
the transgender stuff. That one's bad. It'll be our next podcast. I think I've done enough podcasts on that.
Yeah, I'm sure.
I mean, I've had guests on who have transitioned and now are like, hey, they're advocates against it. This ruins their people's lives.
I'd love to see the research on regret, because that's data that's important if you're going to do an informed consent.
Yeah.
But it's very difficult to do research in this topic. Either people have a foregone conclusion or you're dismissed from the discussion. So we're going to keep speaking up, those of us that feel that it's important to challenge deeply held assumptions in medicine.
Well, it's just frustrating that you go to a conference and like these are the topics. This kind of woke stuff, like because there's real problems that need to be solved in healthcare.
Cure cancer at some point,
Yeah, that's a thing. There's Alzheimer's. These are very costly, devastating diseases. It just seems like that would be something good to talk about. There's a fertility crisis in our country.
Yes,
nobody's talking about that. Yes. I'll make that. I'm going to make that topic the main part of my healthcare summit. Actually, coming up in November. Because I've met some amazing doctors that are pioneering that. So there's important things to actually talk about and interesting and uplifting things too about innovation and things that people are doing that just nobody's want to talk about. Transgender surgeries. It's like, why?
It's like health equity. Vanderbilt will spend $1 million trying to meet the new Department of Health and Human Services requirement to demonstrate they're working on health equity, but they don't accept Medicaid patients. And it's like there are these giant blind spots right now that no one's talking about. All these people pushing this health equity agenda, which, I'm not against. I believe in equity. We all believe in it.
Yeah.
But
how many the utopia I outlined kind of in this conversation, it takes into account people who can't afford care. Right? That's right. We agree on that.
That's right. And how many of these people who are, zealots on the health equity agenda are making a call to somebody who's on the board of a college to get their kid into school or a private school. So these old-fashioned legacy networks live strong with a lot of lip service to health equity. Right. Our research team is actually dealing with the real health equity issues.
Yeah. Well, that's a good place to end. All right, Marty.
Great to see you, Dan.
Yeah. Thanks for everything you do, and thanks for coming on.
I enjoyed it. You do real deep dives here, so that's cool. It's fun.
Yeah, it's fun. It's fun. That's why I keep doing the podcast, because it is fun.
Keep up the good work.
Thanks, Marty.
Great. Thanks, Dan.